So I have no relevant disclosure. Like every cancer, we have a successful treatment. When the systemic treatments, we try to bring them to the earlier stages. So I'm going to talk about some rationale, the using of the systemic immunotherapy in a non-muscle invasive bladder cancer. There's a study showed that higher baseline PD-L1 expression in a non-responders to the BCG compared to the BCG responders. Higher tumor cells PD-L expression predicts like a localized stage progression, independent of the tumor grade. And PD-L1 is the highest in the CIS and the granuloma tissue in the patients who fail to respond to BCG, and also PD-L1 expression significantly increased with the BCG treatment and the people that did not respond. And also showed that increasing the higher PD expression in the BCG relapsing tumors is associated with the subsequent tumor recurrence and the progression. So this led to the first trial that we discussed already, is a pembro. It's a single-arm study that they reported in two different studies. One is like for a patient with a CIS, and it shows like a 3 months CR is about the 41%, and the durable response in the 12 months was about the 19%. And I argue here, one thing is here. If you look at the number here, I go back. So if you look at the people here, as we discussed, the people with the T1 disease or invasive is only 12% of the patient population. And my first question is that if systemic immunotherapy is going to work for a non-invasive tumors, if you believe that they might have a best response for a micrometastatic disease, so what's the point to use it for people with a non-invasive tumor? Maybe we should focus on the high-grade T1 group. So this is a second publication from the same concept. This is for the papillary tumors without CIS, people with the T1 and TA. And you see here, 40% of the people has invasive tumor. And here in a 12-month disease, high-risk disease-free surveillance survival is better. It goes up to about the 43%. So this goes to the next one. It was like a ATISO trial that was like a closed because of futility. It showed kind of similar result, and the 6-month CR rate was at 27%, and the 8 months event-free survival is about the 49%. As you see here, is like a more T1 disease, and the results was a little bit better than the prior results. So other studies, like similar result or similar concept, we see this coming back with the other study. This is the CORE 001 trial that they use a CG plus like IV pembro. And when you look at here, a CR rate for this combination, the overall CR rate with the combination of the pembro and CG is 82.9%. But if in the BOUND 003 trial that use like only monotherapy with the CG is a 75%. So adding the systemic IO only had a little bit to this efficacy of the treatment. And you see here the patient population, again, mostly CIS, and this very small number of the patient had the T1 disease. We go to the Sunrise one, similar result. They had the 3 arms, TAR-200 with sertralimab, TAR-200 monotherapy, and only sertralimab. And if you look at here, the results is CR rate, same thing. The monotherapy with the TR-200, it's 83%, and the monotherapy with the IO is very low actually by itself, 46%. And the combination is something between them. So again, comes back to this idea, do we need to give a systemic IO for the people with the non-invasive, or we just focus on a T1 disease, or people that we have some market that we predict they have a micrometastatic disease or higher risk of progression? So what's the concept of the combination of the BCG and the systemic immunotherapy? So first of all, there's like the data is very inconsistent, that predicting based on the PD, PD-L1, and how they're going to respond. There's a two theory, one cold tumor versus hot tumor. Maybe the people, they don't respond to the BCG, they don't have an immune response there. There's a cold tumor, and adding IO is not going to change anything. So maybe we should trigger that they change that environment with the other treatment, like a gemcitabine or other treatment that make the tumor be hot, and then IO works. Or they have a similar group of people have a benefit from the BCG, they have it from the IO treatment. So by combining them, there's no significant benefit. So hopefully with this trial and the combination of the BCG and IO, we're gonna find out, and we're multiple them, and hopefully the Potomac results reported soon, and then we know that there was the benefit and the role of this combination in the BCG naive patient. As you all know, that systemic IO has lots of side effects. Some of them could be permanent. And concept of that, why not we give it intravesical? So that's the first human intravesical pembro that with the Josh Mix group that they treated patient with the intravesical pembro, and they showed that it's safe, feasible, and capable that to induce a strong immune response. So my conclusion slide. So a few questions we need to answer here. One, patient selection. When we compare the risk and the benefit ratio, is a high-grade T1 disease should be included, or people with the CIS or non-invasive high-grade TA? Patient with the BCG naive exposed, or we should focus on the BCG unresponsive? The cold versus hot tumor microenvironment. Should we combine the IO with some agent that change the microenvironment some and make it hot and immunogenic? How about the intravesical? Should we focus for the non-muscle invasive with the intravesical in the absence of the micrometastatic disease when we think about the side effects? Also, as we discussed, we need a prognostic and a response biomarker. How we can elect the patient that have a higher risk of progression or having the micrometastatic disease that might have a benefit from systemic immunotherapy. And the other question, when we treated people with the systemic immunotherapy, they usually have a first some worse outcome, but then it gets better, have a longer tail. How we can, in the non-muscle invasive, we interpreted that response? CR in 3 months is a appropriate response for the people on the systemic immunotreatment? I don't know. So I think that's my slides. Thank you.
Let's open it up to comments here on the thoughts now, moving to more systemic versus local therapy.
I have a question for the urologists in the group. So with all these intravesical therapies, and they're not all overlapping, so I'm sure there'll be a question of sequencing. So is that something that will become the future instead of radical cystectomy? I mean, considering the costs and the visits and...
Yeah, we both picked up the microphone quickly. Yeah, as Bernie has said many times, I think we have to be really careful. The patients who go from intravesical therapy to intravesical therapy and have silent progression of disease, you miss that opportunity. The window of opportunity for cure with a radical cystectomy may be small. So we have to look for these markers of progression, whatever they are, whether it's radiographic, whether it's amount. Something we haven't done in the past is quantification of CIS. We just say CIS, present or absent. And perhaps in the future, we need to quantify it. Somebody who goes from a bladder filled with CIS to a focal, biopsy is considered failure, as is the one who has extensive CIS. So the answer is yes. I think we'll do it on a random basis for the next foreseeable future in the next 3 years. And randomly, someone's gotten gemdosi. Now they're getting, drug A and then drug B. But I think once we figure out the additive effects of these drugs, the next set of trials in the next 3 to 5 years is going to be the sequencing question. But again, word of caution.
There is an implicit challenge here. Keynote 57 benefited from the lack of mandatory biopsies. But the reason they put in mandatory biopsies is we're not great at seeing CIS, right? White light cystoscopy will miss it. Blue light cystoscopy is better. Not perfect. Cytology is very imperfect. We all like to think that cytology is great. The historic literature said it was 80 to 90% for high grade. A lot of contemporary literature suggests it's maybe 50 to 60%. Probably correlates with volume of disease and things like that. And so, and we all have cases of metastatic disease in patients who had CIS alone. And so there's never going to be a perfect strategy of sequencing that will capture every patient and every evasion. And if you look at even the retrospective data, granted half the patients in our retrospective series of, it was 470 patients, had gotten just more BCG, but the other half got other things. And the death from bladder cancer is around, by 5 years, is about 10 to 15%. And metastatic rate was higher, and cystectomy rate was even higher than that, more than a quarter. And so it's not going to be a perfect strategy for everybody, and I don't even know if we'll be able to identify who it might be a perfect strategy for.
I'd like to ask the medical oncology folks a couple of points here. First, how many examples of changes in standard of care in medical oncology are there where a single relatively small phase 2 study led to that change? Think about that one for a minute. And the second is, how many phase 3 studies have you seen where the results are as good as the phase 2 studies? Maybe you could talk to that.
I can't think of any small phase 2 that, except in the accelerated approval process. But the EV Pembro is actually, the data probably was better in the phase 3 than it was in the phase 1. So certainly that's probably the only exception to the rule.
Yeah, the 1108 with durvalumab was phase 1 that led to approval, and then durvalumab was withdrawn. Same thing with like Atizo was approved, and the phase 3 was sort of negative. So I feel we are rushing getting a drug approved, and fast forward, it's being withdrawn. So we are definitely not doing a good job. And the drug may be working. The study is going to be negative the way it's designed, or for whatever other reasons. So we'll keep losing drugs.
But I think that does show the importance of confirming comparative benefit. We've had so many drugs and so many trials where I've sat at advisory boards and everyone was like, yeah, these GemCis, GemCarbo IO trials, it's going to be the next great best thing. And well, it didn't work so well. So a lot of times what we think we know, we don't truly know. And that's why having those comparator arms becomes so important, and why the FDA has recognized that need, especially for metastatic disease. I think it's something to think about. Even in superficial tumors, you have a lot of novel options, and even some thoughts that BCG might be performing well in that group of patients. Maybe it is the opportune time to try to determine which one is better. That being said, I look at all of the renal cell carcinoma trials where they're all comparing themselves against Sutent, which I think everyone would probably agree. I don't treat renal cell, but I think most people aren't even using Sutent except for on a clinical trial.
So this is going to harken back to me hearing over and over and over again Steve Rosenberg in my ear tell me, as a surgical oncologist and an immunotherapy fellow, both of those fellowships, it's the same thing over again, which was, number one, in order to do and move the bar for immunotherapy, you need to do a phase 3 randomized trial for a drug to prove and get that drug approved. As a surgeon, we could do whatever we wanted in the operating room and just do it. And so to answer that question, I think the bar is much higher in general for drugs, but how different specialties approach that is obviously different. The second point, which about phase 2 trials translating to phase 3, Rosenberg would have said, if he was in this room, he would say, I hope to get the therapy now before it stops working, meaning that the majority of phase 2 trials have died on the vine as they go to phase 3. So I think that, will we be able to do within our confines phase 3 trials? Maybe not, but maybe we don't have to. Maybe once these things get approved, like you said so eloquently, that we have the power to test them in real world settings in a large, multi-center, multi-group collect all the data of these agents, and those won't be 100 patients, they'll be thousands of patients, because the pharma companies are going to want these and going to try to get these things used in the real world setting.
Well, I mean, we are so thankful that we have some options to test, and we want to strongly encourage pharma to continue to try to push the bar forward. But I do think there's a little bit of work that we need to do on our sides to establish what that true efficacy is, and that'll give some clarity as to exactly how these agents should be used and maybe sequenced. So,
but I think your point and Tia's point is real about these patients that can progress. We have lots of things that we can give them, and they will keep looking for them, and they will keep trying to find them. And then you have to sit down and have the conversation. No, we really should do cystectomy and, you know, take your bladder out and take your lymph nodes out, because you're getting to the point where this is your 5th treatment now.
so I think this goes to answer Shilpa's question, which is this going to eliminate cystectomy in this group of patients? It's kind of yet to be determined. We may be kicking the can down the road in most folks. So, okay, to stay on. Yep.
One last comment. I'm a big fan of systemic therapy, but as a radiation oncologist, I'm going to say this. So in 2012, there was a landmark randomized phase 3 trial that was published in New England Journal that compared radiation to radiation and chemotherapy, the BC-2001. And that was known by many as that showed you should give chemotherapy, systemic therapy with radiation therapy. But it was 360 patients. Half of them got radiation by themselves for muscle invasive. And the control rate was over 50%, 50 to 60%, 54%, which means that radiation therapy in a more difficult setting than non-muscle invasive works by itself. And it was 10% better if you had a sensitizer, which means that if the radiation therapy works 50% of the time, what's the threshold for giving a drug that costs $300,000?
I think one of the other challenges is what we're hearing all along, that patient selection matters. And that's been the challenge with cross-trial comparisons, the idea that we're now seeing cohorts of patients who might do better with a third round of intravesical BCG, which implies selection matters. So whenever we look at all of these trials, we start seeing all of these differences in the patients who were enrolled. Trials like the radiation trial, which accrued a larger number of stage 2 tumors compared to the Swag-Inter group trial, which enrolled larger numbers of stage 3 tumors. So I think this all stresses the importance of comparison endpoints so that hopefully randomization allows us to control for that and truly understand the degree of benefit in a cohort of patients.
Oh, it's a great point. The Credo data that was presented a couple of days ago had, I think 80% of that cohort was CIS only. That doesn't look anything like my practice. And I know that with, small volume CIS maybe picked up with either blue light or NBI, you could pretty effectively get rid of that with your TUR and roller balls as well. So you're absolutely right. It's a little difficult to compare this. We've gotten better at doing these phase 2 studies, and it's probably time to move on.